Good afternoon. Warm welcome, everyone. To start, may I invite Ms. Sonalini Ketrapal to provide a brief overview of this webinar. Ms. Sonalini is a senior health specialist at ADB and is the team leader for the health portfolio in India and Bhutan. She is leading the design and implementation of projects worth over. These projects all have large components on digital health as part of the country's health sector reform initiatives. Please welcome Ms. Sonalini. Ms. Sonalini, you have the floor.
Thank you, Lisa. Distinguished colleagues, partners, and friends, it's a pleasure to join you today to discuss a topic that is rapidly reshaping the health sector across the world and the role of digital solutions in strengthening health governance. Over the past decade, and especially during the COVID-19 pandemic, we've seen digital technologies are no longer optional enablers. They are now core components of resilient, responsive, and people centered health systems. Whether we are talking about real time surveillance, digital IDs, supply chain visibility, data driven financing, or digital systems that have now become essential for how governments make decisions, allocate resources, and deliver services. Yet, the power of digital transformation lies not in technology alone, but in good governance that surrounds that technology. The policies that ensure data is ethically and securely maintained, institutions that sustain digital platforms beyond just pilot projects, which we've all seen enough of, the standards that allow interoperability across programs and sectors, and the financing arrangements that make digital public goods viable in the long run. Effective digital governance enables ministries of health to see the full picture of disease trends, workforce planning, financial flows, and service quality. It helps leaders to act earlier, allocate better, and respond faster. And when done very well, it improves the transparency, accountability, and trust, which are all essential ingredients to a well functioning health system. But we must also acknowledge that digital transformation is not automatic nor evenly distributed. Countries face challenges of fragmentation, cybersecurity, capacity, and the need to design digital systems that surround real user needs. Frontline workers, whole human resources for health workforce, capacity managers, and citizens themselves. Addressing this requires long term partnerships, predictable financing, and a shared commitment to building platforms, not projects alone. Today's dialogue is therefore vital. By learning from one another, by aligning government leadership with development partners and the private sector, and by investing in scalable digital architecture, we have the opportunity to shape health governance systems that are more integrated, intelligent, and inclusive. I look forward to our discussion today and to a collective insight that will help us advance digital solutions that are not only there to innovate, but truly serve the public good. Thank you.
Thank you, Sonalini. We have a lot to cover this afternoon. Okay, to welcome guests and participants, we are deeply honored to have Dr. Eduardo Banzon. Dr. Banzon is the director of the ADB Health Practice Team under the Human and Social Development Office. It was Dr. Banzon who started the webinar series, and now we are at 24th, and more webinars to come. Dr. Banzon, you have the floor.
I thank you, Lisa, and of course, thank you to Tashi, friend from Bhutan, Chancellor from Laos, and all our other guests. I'm actually taking this call. I'm actually making this message from Indonesia. I am in Lombok, and just shows to us the power of digital. Of course, probably even 10 years ago, it would be hard to make this call. 20 years ago, it would have been impossible. Now, we all communicate from whichever part of the world. So, Nalini is, of course, from India. She's still in Delhi, I believe so. And of course, Tashi is in Timpu. And again, this again highlights the power. Chancellor is in Vientiane, so our list will go on and on, just to you the power of how, if we embed digital health, digital tools in health systems, the more that we could really make a difference. I actually argue that we should change the definition of health systems that make digital embedded. That means we could not have a health system unless it's digital, because not to do so basically means wasting a very powerful resource. Health systems is so data driven. We make a lot of our decisions using data, whether we are in clinical care, whether we're health financing, whether in quality assurance, whether we're managing hospitals, and health is all over. We believe, we always argue that health is multi-sectoral. So the more that we really need data, and in a sector which is health, I'm sorry, I have to move my phone. That's so digital it is, but it is going to be a disservice if we don't integrate digital tools. Now, what's great, of course, is because the delay of the health system and incorporating digital means we now have an opportunity to leapfrog, to jump, right? To pole vault. That means we don't have to suffer the lessons that other sectors have. And maybe you could just move into a world where QR codes are there, where everything is digital, where we capture data using TikTok and whatever interesting and bright presentations you'll be doing. So we welcome everyone, both who are listening right now, and I believe, again, the power of digital, who will be listening to the recording of this webinar. And let's hope to have a very exciting. The only thing they'll miss is they won't ask questions, but who knows? They could always send questions to everyone and you could answer later. But let's listen to this wonderful world of advancing health systems, advancing UHC with digital tools. So again, welcome everyone, and excited to listen to the speakers. Lisa?
Thank you, Dr.
Lisa, we cannot hear you. Lisa?
He has been involved in the development of the National Digital Health Strategy, as well as in the implementation of various digital health solutions. Please welcome Dr. Chansali.
Oh, Malila. Oh, I'm the first speaker. I didn't hear you saying that. All right, I think I can share my PowerPoint now.
Yes.
Can you see the screen now? Oh, okay.
There is an echo, Dr. Chansali.
Maybe join it to be echo now. Join.
โดยน้องพยายามอยู่อย่าใส่ซูมแต่มันก็บ่เห็น
เมื่อกี้คือแชร์ได้อยู่
ปิดเสียงของน้อง
แต่ว่าแชร์สกรีนมันบ่ออกเลยบ่เห็น Can you see the screen now? I couldn't see it.
Dr. Chansali, we could see your screen, but it was not the presentation, it was something else.
Yeah, maybe Joy, can you share the screen now?
Now,
okay, now.
yes.
Now, okay.
Now we can see it, the presentation.
Okay, next slide. So thank you for everyone for patience because first I would like to say that our minister cannot available to participate in this important meeting. So they given to our Department Planning and Finance on behalf of minister. Okay, next slide. So the digital health strategy has been based on this main two documents, because health sector reform and also the health sector development plan. Now we already have a draft of the 2026-2030 health sector development plan. Already have. Next slide. So actually, the digital health strategy is based on the digital transformation of the government, not only health sector, but the government have a policy on the digital transformation, digital economy, digital society, which and then later on when we have the next slide. So we start development of the our digital health strategies long since 2020 2022, and then by the end of 2023, we have several meeting with the partner, with the development partner, also all the health sector, and then we come up with the digital strategy based on the also suggestion on the concept of the AHIN in the Asian Electronic Health Network concept, the GAP concept. Next slide, please. So this is the digital health strategy in Laos 2026, 2023, 2027. Actually, is this report already available in the website, and anything that you need, we can further sharing to you. Next slide, please. So we building this strategy is based on the principle that we are built on the existing work, meaning that based on the what electronic health information system already running in the system, what system we have. So we also focus on the need, or the basic need that we need in our country. So we develop this strategy based on this. And also we choosing the pragmatic over the idea, meaning that how we can make this strategy implementable, and also the can be implemented. And also we also based on the national goal, meaning that also we are just based on the health sector development plan, based on the government digital transformation policy. And also when we cost this strategy from 2020 to 2027 is also not too high, so we can implement. Next slide, please. We also based on the principle that data-driven initiative, meaning that we want more focus on the quality of information, the quality of data available to people can use it for planning and for monitoring the progress of the indicator. We also based on the interoperability. Any system that and in the digital strategy could be interoperate each other, so that data can be shared. And another one is also based on the principle of open source software. Any software that they will apply, we think that it could be gone into the open source, so that we can customize, we can integrate with other systems. Also, we are working together with government and other partner to develop this strategy. Next slide. So actually the strategy is based on we have 5 pillars based on the AHIN system, and the GAP, meaning the workforce, governance, standard, application, and infrastructure. We are ranking first workforce, and second governance, standard, and application, and the last one infrastructure, because of based on the score, because the assessment score of the digital in Laos. So the lowest score is workforce. That's why it's come up the first one. Next slide. So the strategy have, as I said, they have 5 strategic priority: workforce, governance, standard, application, and infrastructure. If you're counting the boxes, there are 16 strategic objectives. And if you're counting small boxes, about 37 strategic project, small project. And under each project, they have about 116 activity, which is we already tried costing and already given to the different department and center, the owner of implementation of this activity. Next slide, please. So let's start from the first pillar of the strategy is we call the workforce, because when we conduct the assessment of the digital system, the workforce is the lowest score. So we try to focus on this. So far, because of the strategy already has been implemented since 2023 up to now, it's already midterm. So far we had some progress. For the first one, is you can see the green boxes, meaning that we start to develop digital leadership capacity, meaning that we already sending some government staff to have trained in the abroad. So far we already get one PhD student already come back from Japan, already on board now in the country. Another 3 master degree is still ongoing in Thailand, and they will finish, they will complete the training this year, maybe June, July, something, for the whole 3 people. And we also have start working with the community volunteer to support digital activity, because under the WHO support, we have already trained village chief and at Vientiane capital, Vientiane province and Sengkang province on date notification is linking to CRVS, Ministry of Home Affairs. Next slide. So second pillar, we come to government. And the government also, as I mentioned before, that after we complete the development of the digital health strategy, and we also further drafting the digital committee. That committee has already been approved by minister, and also is already in line with the Ministry of Technology and Communication, which is leading the digital transformation. So we also, aside from that, we also have conduct regular because technical working group to report and update on what the progress of the digital strategy implementation. So far, we from 2023 now, we already had conduct the 5 time technical working group with partner and all the health sector department. Aside from that, we also have now starting forming the we call digital cooperation office, or we name it integrated and development of digital health strategy. So far, we combine many partners that support the technical team, IT team in this office to work on to coordinate on all the digital activity in health sector. Next slide, please. So the third pillar is talking about standard. This we also have a lot of progress on this. First we talk about establishing a health ID for all clients. Now maybe you can hear from speaker from Sam and John talking about it. We are now already have developed we call the client health registry. We already finished pilot in some province with support from different partners to implement the client health registry. More detailedly, maybe Sam and John will be more elaborate on this. We also have to implement the because health facility master list, meaning that all health facility naming and all the things already standardized and already integrate into the main system in the SSO system. And we also established we call the minimum set of data for client health registry, meaning what we are going to collect in this client health registry. Next slide. So another standard, we also the same thing. We already have a pilot in the Vientiane province, and we already established the coding of morbidity, mortality with support from the WHO and the Department of Healthcare. We already the ICD-10 has already been translated into Lao language, and we also working on this together with WHO to integrate into the DSO2 system. Next slide. So another pillar of the strategy is application. So this also have some progress on this the implementation of the digital health strategy in Laos. So actually, as I mentioned, that we are going to implement which we call the electronic medical record in Laos. So now we have a lot of hospital in Laos now just starting to apply the hospital information or electronic medical record. We have been conduct the what we call assessment together with WHO, the partner like ADB to assess what the whole country of Laos, which health agency has already been implement the electronic medical record and what kind of software and how this the software is integrate to each other. So we already conduct this assessment, and we have the task that we need to give in to the Ministry of Health that what kind of software we are going to implement for Laos for the electronic medical record or hospital information, and how we can link this existing system that we have, like a DSS2 and other system in running in the health sector. Next slide, please. So we also implement, aside from that, we also got funding from different partners like World Bank and to implement the lab management information system through the national this is surveillance system, and we call it NCLE, which is starting from try to link in the lab for the TB, HIV under the World Bank project. We also have implement the we also have discussed among Ministry of Health with the Department of Food and Drug and also the we call it medical supply that because they are owner of the M supply system. So we are also talking about how we can turn this M supply system into the open source, because the current system we use the license M supply system, because we have to pay the government to pay for license every year. So how we can turn this into the M supply open source? We already have discussed with the ADB and other partners how we can make it more open source system. And also we have the project has established the national health insurance system. So far, the insurance system had already been started. We call the billing system, but the task of the our Ministry of Health or to implement the digital strategy, how this can link to the current system, this SS2, how we can link to the hospital information system that already operated in different hospitals. Next slide, please. So the last, because of our infrastructure, we also need to continue getting support from other partners to update the system, meaning that we need to have the what we call the infrastructure like internet, the computer, other applications that used to implement digital strategy. Because without this infrastructure, it's really difficult to implement the digital strategy in Laos. So far, with support from different partners, all the health center, all the district hospital have already have the internet, so they can use this for enter the data for at least for DCS2, and probably we can try to link this system using different software, different application in Laos. So this is the main digital strategy, the main strategic, and also the activity, and also what the progress of the infrastructure development or implementation of digital health strategy in Laos. Next slide. So, so the next step, what we are going to do, I think probably we need also to stronger leadership and coordination, meaning that even despite that we already have the steering committee for digital health strategy implementation, but we still need to have further put in a sub policy like a regulation, a rule, how we can implement this strategy. And we need to also update it and review digital strategy, meaning that the strategy has already halfway to implement, because by the year 2027, so we can have all people can make a decision based on their own information. We also need to put more budget to implement in this strategy, especially the budget from the government. We know that the government have very little put the money aside from we have the loan budget from World Bank and ADB, and the rest we are based on the partner to support. We also need to strengthening data quality and the use of information. The more people use, the more quality will improve. We just recently working with different partners like UNDP and other, so that we can strengthening the quality and strengthening the use of information of the system. And yes, we also need to invest in also the infrastructure and for this to implement this digital health strategy. And as I said, that we are now under the reshape system is the main platform for health information system in Laos. So we already starting moving from program centric to people centric, which is maybe Sam and John can be more further discussion on this. So I think this is the end of my presentation. If you have any question and to clarify, you can go ahead. Thank you.
Thank you so much, Dr. Chansalee. For any questions, maybe we can reserve it after all the presentations, if it's okay. Thank you, Dr. Chansalee. Okay, so moving on, we have another presentation from government. This is from Mr. Tashi Penjor. May I invite Mr. Tashi Penjor to healthy digital environment. Mr. Tashi Penjor is the Chief of Planning Division of the Ministry of Health. He is the focal for ADB Finance Health projects. Mr. Penjor has also authored and co-authored several publications, including on information governance. So, Mr. Penjor, the floor is yours.
Can you confirm that you can hear me, Lisa?
Yes, we can hear you, Mr. Penjor.
All right, and the presentation is in full screen, right?
Yes, it's full screen.
Okay, thank you. So I will straight away start in the interest of time. And by the way, Dr. Chansalee, thank you for this very wonderful presentation. My presentation would seem a bit prehistoric compared to yours. And there are a lot of things that I'm learning, catching from your presentation. It seems there's a big investment already happening in Laos. So I'll take you through my presentation. So it's a big topic, but that's it. I'll try to give a big picture about the topic, about what's happening in Bhutan, and then narrow it down and bring your attention to health sector. So if you view on the screen, there is that overall e-gov policy. In short, we call it e-gov policy for Bhutan. So that actually, determines what do we do with the digital ecosystem as a whole. So now there's this very bold move by the government in saying that whatever we do, we'll go digital by default. So this is a very big agenda. So whatever we want to do, we will go digital by default. So this is something that the nation is preparing going forward. And then also there's that consolidation. So all agencies, whether it's health sector or agriculture or the civil registry, whatever it is. So the advice is that we reuse, re-engineer, and then share common digital ecosystem. And then coming to the health sector, we have our own national health policy. So that actually determines and also tells us that all medical services, so it's very clear for the health sector, all medical services are provided online. So for us, this is a very, what you call it, abstract sentence, but we take it very seriously. So going forward, if you look at what we are doing now with the support of ADB, we have invested close to 1 billion Bhutanese miltam in rolling out the electronic patient information system. So I think this is where ADB is coming into the limelight for investing in the health sector. Then what we have is revised in terms of the strategy. We have revised. It used to be a national e-health strategy in 2018, and that's also a costed action plan. But now recently we have the final version of our national digital strategy. So this is a costed action plan. A lot of avenues where we can invest going forward. Then in the health sector alone, if you in Bhutan, it's a small country, just like Lao PDR. But if you look at the number of systems that we have 38 digital health systems. And then, of course, we were using it in a very fragmented approach till we tried to, bring it all together. But this, was useful for us during the COVID pandemic, which accelerated the opportunities from digital solutions and platform. So Bhutan was able to do a lot of things through digital technology and platforms and also solutions. Then in terms of the soft component, so actually I wanted to mention that in our experience, in our very infant experience, what we found out is that the soft component should actually precede any investment in hardware, hard component, hardware, the digital ecosystem, DPI. So for Bhutan, what we looked at other countries is that we readied our soft components, the legal frameworks, the legislations, the strategies, the action plans, and then of course finally the governance structure. So this is a very simple governance structure that we have in Bhutan. So now we have this National Digital Health Steering Committee. So it's chaired by the minister. So we actually wanted to give this limelight as well as political support, because without that, resources are really constrained for a big agenda. So then we have this steering committee. So this steering committee is supported by, a technical working group, which is multi-sectoral. So we have from the GovTech, we have from the civil registry, we have also from our own medical physicians and professionals, and also, of course, people working in the health information and health information system. Then we have a full-time digital health secretariat that ensures that this agenda is continuously is programmed, is re-engineered, is also put into the limelight of the National Health Sector Strategic Plan. So after this has been formed in 2018, Bhutan's experience is that the health sector actually, because we wanted to invest in this electronic patient information system, so we then actually negotiated, we tried to seek the support of the government by trying to say, at least in all the health facilities, and by the way, Bhutan, of course, is small, but all the health facilities by the challenge of geography is really scattered. So there's that phenomenal challenge of connectivity. I'm sorry. So what we did is we then tried to push our agenda to the GovTech by saying that we will put some amount of money, and the GovTech also does this cost sharing for us, and then we invest in improving the digital ecosystem. So then what we had before we rolled out the electronic patient information system is that our health facilities, the digital public infrastructure in the health facilities were almost satisfactory and adequate, so that we could then initiate any digital actions we want to do with the health services. So this is a snapshot of what we did in the electronic patient information system. We have close to 38 modules developed. This is what we have in the now currently. So this is now we will be re-engineering this by next quarter. So these are the modules that we have. By PR means priority. So we thought, where do we want to place our priorities first and then go next sequentially. And also by implementation, we phased out actually. So we first choose 10 health facilities by different levels and variety of services. So then it's almost like piloting. So we then, at the end of that phase one, we try to then evaluate, to use the word evaluate. Then we try to see what are the lessons, what are the areas we could improve, what are the redundancies, what are duplications that we can avoid. So then in the second phase, then we taking the lessons from phase one. In the second phase, we try to implement this and roll this out in all the 49 major big hospitals. So, because then in the third phase, which is the primary healthcare center, which is the basic level at the community, it was much easier. So at once we did it from in a few months. So this is one of the principles that we use, this pictorial view. So what we did is that we say, because we had this fragmented 38 systems, then interoperability is essential, because we then cannot try to pull all the independent systems and then rebuild new ones. So we re-engineered our architecture, EA, and then said it must be interoperable. To the extent that we are now connecting this to the civil registry so that we can also improve on our birth and death notification and also autopsies. So these are a few things in our experience quite useful for us, like using application program interface, which are open. Then also, of course, I mean, global health standards we cannot escape. So if you use that, I think these are standards that will really help us improve whatever investment we make in digital ecosystem. For example, I mean, with the electronic patient information system rolled out nationwide, what we were able to do, Bhutan perhaps, now we proudly tell this to all our member states, is that we are the only country now to officially implement ICD 11. So in all our health facility, of course, it's facility based. So now we use ICD 11 for disease coding, mortality and morbidity coding. So these are a few things that we achieved. If you look at the picture, maybe it is more clear. So this is how we linked the National Referral Hospital, the Regional Referral Hospital. Also, there are other hospitals which does not fall within the purview of Ministry of Health, which is the army hospitals. But now they do all this reporting to us. So since we have all this information, we are able to now, what we call it, regulate what are the services they offer. Are they being offered as per national standards? Are all these standards being fulfilled? So this is the power of digital solutions, to be able to regulate facilities, not physically under our purview, but now through data and evidence, we are able to now regulate and tell them. So key lessons is standardization. So Bhutan cannot, afford to have this standalone standards. So what we use is, again, as I said earlier, there are established global standards which are very useful. For us, our job became easier when we rolled out to roll out the EPIs using the global health standards. Of course, we had this experience of using health solutions almost a decade ago. But what we learned is that the primary failure is because of not being able to bring in stakeholders right from the beginning. So this time around, what we did is, even before we rolled out EPIs, even before we adopted ICD, moved to ICD 11, what we did is we built our network. We built in physicians, we built in coders, we brought all of them together and said, this is how we want to go about. What are your contributions to this? How do you feel? So I think this was really, important, because as we implement, we already have them leading for us. So this is something, that we learned from our past mistake and also from the current, achievement, as you may call it. Then phased deployment workspace, because of course, it's like piloting, as I said earlier, because this gives us opportunity to re-engineer, fine-tune, and also bring in new, modules, redundancies to be removed. So phase development, at least for Bhutan, was perfect. Challenges, of course, are very common in, I think, most resource constrained countries like us. There are these infrastructure constraints and there are resistance to change. We have close to 6,000 health workers with us. Not all of them are IT literate. So, I mean, they do not easily espouse change, especially when it comes to digital solutions. Some of the physicians were very candid in saying, now, I mean, this is something that challenges our, what you call it, physical ability to give services. So this, I mean, has to be properly recorded. And then we have to also see how do we actually bring all these challenges together. What are the efforts that we can do to mitigate this? So these are things that we listed out before we actually implemented. And of course, huge gap are there in terms of data quality and completeness. In Bhutan, that's why I refer back our attention to Lao PDR's presentation. So in their indicators, it's very clear what do we really want to assess by different categories. So health workforce is something that I'm really interested to learn more from Lao PDR. So this is something that is going to be a future challenge for Bhutan as well. And then sustainability and funding is, of course, a common challenge. So these are opportunities we see going forward. We have further integration to be made. For example, we are using certain solutions like internet-based cardiotopography. So right now, because Bhutan has very less specialists in terms of MCH services, gynecologists. So what we do is we rolled out nationwide something called the internet-based cardiotopography. So it's like an iOS-based system. So the specialists in the capital city can monitor close to 85 health facilities at a go. So these are opportunities that we see. And then, of course, telemedicine and remote care capabilities. Now, more and more, Bhutan is facing the burden of NCDs. Close to 70% of our deaths are from NCDs, attributable to NCDs. So we are also thinking about the spoke and hub model in which we could expand our care because we are very, minimal critical health physicians here, specialists. So we thought expanding remote care through telemedicine is a possibility. So these are things we are working on. And there are opportunities to use advanced technologies. So now with the basic facilities and solutions in place, we are now, for example, we have now, through the APEX project supported by ADB, we are also using digital X-ray. So this is very feasible. So we have rolled this out to 7 facilities, and then the feedback is really good. So we are also now trying to replace the conventional X-rays with the digital X-rays. Of course, the last one is for people like us. So we want to use all this data. So there's this opportunity to use this big data is already there now. A lot of data in the system. So we wanted to use this to make evidence-based policy design, program development, and decision makings. So this brings us to the close of my presentation. If there's any questions, I'll be happy to take. Thank you very much.
Thank you, Mr. Kanjor. Okay, so we can arrange a meeting with between you and the Lao PDR later.
That would be great.
Yes, we'll do that. Okay, so for our next speaker, there are a lot of questions now coming in. We can discuss those questions later after all the presentations. Okay, so for our next speaker, Mr. Jean de Guzman. Mr. Jean de Guzman is with both MD, a Singaporean health technology company focused on AI enabled solutions for healthcare. He is currently the country manager in the Philippines, as well as regional head of customer success for Asia Pacific. Mr. Jean de Guzman.
Hello, Lisa. Can you see my screen?
Yes.
A full screen, please.
Okay, thank you and good afternoon. It's a privilege to be part of ADB Secure webinar series. So I'm excited to share our experience on how we supercharged health access using AI. So let's dive in. So the scene you're seeing in this picture looks familiar, right? So these are hospitals. You imagine the situation in smaller healthcare institutions like municipal health clinics, right? So my wife was a rural doctor in Palawan, serving 3 island barangays. Now, apart from dealing with a horde of patients as a physician, she was also chief health officer running the health programs in her area, nurse, clinical admin, janitor. You get the picture. Across Asia and the Pacific, health systems are stretched thin by the rise of non-communicable diseases, growing patient volumes, workforce shortages, and patient compliance to medications and treatment. The pandemic also highlighted critical gaps, such as fragmented data, slow information flows, and limited digital capacity at the front line. If healthcare workers are overwhelmed and preoccupied multitasking, they lose out on focusing on providing healthcare to patients. Now, this is where AI becomes transformative, not as a replacement for human healthcare workers, but as a force multiplier that extends their reach and enhances their capabilities. Digital health platforms can automate routine tasks like appointment scheduling, medical documentation, and even basic triage. Now, this doesn't replace doctors. It empowers nurses, community health workers, and general practitioners to work more efficiently. AI can also enable predictive analytics that identify high-risk patients before conditions become critical. Okay. Machine learning algorithms can analyze patterns in patient data to flag early warning signs of, for example, chronic kidney disease, diabetes, or hypertension, to name a few. Okay, it helps healthcare workers manage chronic conditions more effectively. Now, AI chatbots and virtual health assistants can provide 24/7 monitoring and support for elderly patients at home, reducing unnecessary hospital visits while ensuring timely intervention when needed. Natural language processing can help overcome language barriers, making healthcare more accessible to diverse populations. And that's why BotMD exists, to empower doctors, healthcare workers. How do we do that? We simplify the things that consume a lot of time and effort. The things that you do manually, whether that's being available to answer patient queries, delivering education information, collecting data, or remotely monitoring patients, right? We automate these and enable you to engage these patients with what we call AI agents. So we have pre-trained AI agents that you can use for patient education, FAQ scheduling, data collection, to name a few, and engage these patients directly where they are, their messaging platforms. So what we do is to power your omni-channel messaging with AI using available commercial chat apps. So in the Philippines, no one is going to uninstall Facebook Messenger or Viber because they use it every day. In fact, 92.1% of Pinoys are on Facebook Messenger, not just doctors or nurses or barangay health workers. Actually, even our driver and our household help use it. Now, let me give you an example on how we use our patient survey agent in data collection for remote patient monitoring in the Philippines. 5 years ago, the National Kidney and Transplant Institute, the largest kidney hospital in the country, wanted to better serve their peritoneal dialysis patients, in particular, those living outside Metro Manila. So we sat with them and came up with an automated workflow to remotely monitor their dialysis patients for early signs of infection using Viber and Facebook Messenger. So how does it go? First, patients are registered via a QR code, right? And then upon registration or quote unquote enrollment, they receive a welcome message in their messaging app, together with a link to submit their data via a secure survey form. Now, sometimes patients are lazy or hard-headed or may simply forget to do their submission routine. The AI can sniff out these non-compliant patients and send reminders for them to submit. Now, all of these data flow into our BotMD Care dashboard, where clinical users manage these patients and their submitted data, and quickly spot patients with issues in their submitted readings. Earlier, I had mentioned that AI augments healthcare workers rather than replacing them. This automated workflow saved the nurses from having to call patients one by one to check on them individually or to remind them to submit their readings. The dashboard made it easier for the doctors to easily and quickly see which patients are problematic without having to look at each one's submissions. So it enabled them to put more attention to the patients that need more care. Now, this engagement was featured in Channel News Asia. Let me share an excerpt of this with you. Earlier, I couldn't click on share sound, so I hope you'll be able to hear the sound.
I've come to Cavite in the Philippines, a suburb,
Let me pause that. Can you hear the sound?
Yes, po.
Yes, we can.
Thank you.
Our drive from Manila.
Well, I'm a diabetic patient and I have a kidney complication. And then the doctor told me to have peritoneal dialysis.
Peritoneal dialysis is a treatment for kidney failure that uses the inner lining of your abdomen to filter and remove waste from blood. Violetta Furman performs the dialysis at home 3 times a day, aided by a human caregiver and an AI assistant. BotMD sends Furman daily messages,
Dry cup.
prompting him to send photos of his dialysis fluid and catheter opening.
Meron bang pananakit, pagdudugo, o nana sa iyong exit site? Mayanin ko muna raw sa iyong dialysis site fluid.
Based on these responses, the bot performs a triage and alerts the doctor if there's any sign of an infection.
Nararamdaman ko na malapit lang yung mga doktor sa akin. Kagaya po niya, nagkaroon ako ng komplikasyon. Nasabi ko agad sa kanila yung naramdaman ko. And then, yung response nila agad.
I head to the National Kidney and Transplant Institute, NKTI, in Quezon City to see how the doctors and nurses utilize the chatbot. It's 9 a.m. at the emergency room, and already the place is bursting at the seams. Most of the patients are here because of kidney disease and related complications.
Basically, the patient has peritonitis. Peritonitis is an infection that happens when you do peritoneal dialysis. Abdomen gets inflamed, so we need to admit the patient and monitor her progress in the treatment.
Dr. Donna De Leon explains that they use a chatbot to screen for abdominal infections, and this reduces visits to the emergency department.
The moment the patient feels any symptom like abdominal pain or any complications at home, can alert us and we can address the problem at home.
How has adopting AI helped with patient and hospital management?
We can see more patients now. For example, in peritoneal dialysis, we have 1,000 patients, and we can only see maybe 50 patients a day. Their clinic follow-up visit is 3 months later, when actually we wanted to see them after a month. From doing the outpatient follow-ups by phone, we can actually see more toxic patients who need acute care.
Okay, so the doctors that were interviewed in that feature were our champions in the NKTI. They pushed for the use of the technology. Now, this shows how strong leadership and governance enable digital tools to scale sustainably beyond pilot phases. So imagine that NKTI is a government hospital, and they were actually our very first client here in the Philippines. Just so you have an idea on how that remote patient monitoring program fared, okay, so they were able to enroll over 1,200 CAPD patients. 98% of them were new. Note on the uptake. Because the forms are designed to be easy and quick to fill in, we had 81.2% uptake. That's pretty high. Now, all of the data we're seeing here is why we encourage our clients to automate their workflows and digitize information, because it equates to better tracking, better analytics. That's useful, powerful information. But why BotMD? I mean, there are a number of commercial chatbots available. Our AI is designed with healthcare in mind. Okay, so we use a proprietary RAG LLM model that uses only hospital-approved content that retrieves, not generates, the correct response and makes it appear as if you're chatting with a human. Okay, we implement using a deep understanding of the patient care journey and workflow. So before anything actually starts, we sit down, we discuss your pain points, the workflows. Okay. And lastly, we have all of the security certifications to ensure that patient support is safely scaled. And this is why we are trusted by doctors internationally, serving most major public and private hospitals in Singapore, Indonesia, and the Philippines, of course. In our engagement with private healthcare institutions, we unified patient engagement, linking patient navigation, appointment scheduling, and teleconsult reminders. Now, through that partnership, that's how and learning the private sector can help scale national digital health goals through innovation, right? Of course, and shared learning. Now, let me try to bring all of this together. The challenges we face, workforce gaps, rise of NCDs, aging workforce, even fiscal pressure, are formidable, but they're not insurmountable. AI and digital health solutions offer us powerful tools to extend quality healthcare to more people with existing resources. However, and this is critical, technology alone is not the answer. Okay, we need strong leadership and coordination. Okay, so that means ministries of health must establish dedicated digital health units with the authority and resources to set strategy and make procurement easier, not just react to vendor proposals. Cross-ministerial collaboration is essential. Okay, digital health governance spans health, telecommunications, finance, and technology sectors. Next, we need investment in digital infrastructure and literacy. Oh my gosh, here, especially in the Philippines. The most sophisticated AI is useless without reliable internet connectivity, electricity, and healthcare workers trained to use these tools effectively. Governance frameworks must mandate and fund capacity building. Next, we need public-private partnerships with appropriate safeguards. Okay, so companies like ours, Taggle, and everybody else that will present here bring valuable expertise and agility, and we all can learn from each other. Finally, we need a continuous evaluation and adaptation. Digital health governance isn't a one-time policy document. Okay, it requires ongoing assessment of what's working, what's not, how technologies are impacting health equity. And remember, it will and should always be humans for care and AI for everything else. Thank you. Good afternoon.
Thank you so much, Mr. Gian. That's amazing. No? I hope we can afford AI. Okay. Similar to Bolt MD, let me invite a presentation from Mr. Lee Sengbyo. Mr. Lee Sengbyo has over 3 decades of experience in designing and building complex information communication systems, and he started with defense, telecommunications, and banking, but now he is also into health sector. So Mr. Lee is the founder and CEO of Taggle Health, which is a company that develops and implements digital healthcare solutions together with health sector stakeholders in several countries in Asia. Mr. Lee Sengbyo.
Thank you, Lisa. Well,
Thanks, everyone. It's a privilege to be able to present here. Let me bring up my slides. Okay, so Tego has spent the last decade building what we call a unified digital health platform. And the whole purpose is to enable healthcare digital transformation. I think for a lot of us here, we understand the challenges that is being faced. And today I'll share and highlight what Tego has done in this area. So first off, we know that healthcare is complex, right? And the needs of patients for rehab, chronic illness management, NCD, and so on is complicated, especially when they are discharged from hospital, because there, without proper digital health services, the doctors and healthcare professionals are essentially blind to what's happening. I mean, you can tell them what to do, but have they done it? Have done it properly? Have they eaten the medication, done exercises? You wouldn't want to visit you. And frankly, a lot of them, the patient will tend to so-called say different things and wouldn't admit that they have not done certain things when the doctor asks them, right? So, and if you look at the diagram over on the left side, every patient is different, every illness is different, but there are common sets of things. For example, vital signs monitoring, rehab exercises have to do, medication adherence, and so on. So the problem with this is that on the right side, you'll see that there are many apps that will help address this. For example, diabetes. There are apps that does diabetes. There are apps that does stroke. There are apps that teaches you things, and so on. But each app on its own comes with a separate system, and each of these systems needs separate integration, and all of them are unconnected and uncoordinated. So those are the two main things that Tego wanted to address, because we've seen so many failures, so many apps, clinical trials, pilots that were conducted but never implemented. And again, I think some of the countries have brought up, when they are implemented separately, the cost is simply too high for them to be used in the first place. So what Tego has done over the last 10 years, we have built a single integrated platform, right? So meaning that a hospital, a government, a city would and should just need one single platform to deliver all the digital health requirements that the resident, the patient needs, and have a single dashboard whereby clinicians, therapists, nurses, allied health, and the community health workers and the caregivers of the family can come together and basically do a unified care coordination as well, right? So one platform, the hospital, one platform for all the stakeholders, yeah, because again, hospital can only care for patients up to a certain level. Once they're discharged, a different group of people take over. And in the family itself, the caregivers are normally not able to be part of this system to use the tools to continue with the care, right? And of course, at the national level, the national EMR integration, all the other national health system needs to be integrated as well. Yeah. So that's what Tego has done, and that's why we call it unified digital health platform with one care plan that flows across all the different stakeholders, so that the care for the patient, the citizens, and the residents can be seamless across the entire life cycle. And this is kind of what it looks like. Yeah. So we have all the hospitals, acute care, you have the community health care, you've got the public care networks, the GPs and so on, and the national system. So our platform sits in front of all this, in front of the EMR that hospital have, in front of the clinic management system. We can connect to them when they're ready, but we can be used standalone as well, and through a few different front end, for example, the Health Super App, the Health Kiosk or Health Station. All the stakeholders within the healthcare ecosystem can then deliver prevention for population health, screening, education. They can deliver rehab for people who have illnesses, cardiac, stroke, and so on. NCD, long-term chronic illness management for diabetes and everything else.
And even up to the stage where you look after the population when they're old. So in Singapore, I think in many countries, frailty fall prevention is a major component of their care for the community, because once a senior has a fall, mobility is affected, quality of life drops drastically. And in Singapore, the estimated years of care needed for a person is 10 years. Yeah, we live up to 85. On average, the last 10 years of our life, we still need care. So our platform was created so that it's not just for patient, but even for still active seniors and seniors who are in danger of frailty, so that the government can continue to make sure that their quality of life remains good throughout. Yeah. And one key differentiator I would like to highlight, again, we have heard being brought up, cost is the main concern within many countries. Yeah, because in Singapore, to some extent, the government can afford and they are funding a lot of what we're doing. But in many of the other countries, you'll find that really the cost is a factor. And we've heard the Laos presenter talking about using open source software and so on. So what we want to do is to try and reach a point whereby, even though it's a system developed in Singapore, but the business model, the way we implement it, can be used in a lot of our developing country neighbors as well. So that's why we did a SaaS marketplace model that we can implement for each country, each city, each government, each hospital, without them incurring high costs, but at the same time, allow them to expand and scale as and when they are ready and when they need the service. So this is kind of what it looks like in Singapore, where we deployed for the National Healthcare Group. So this is a public health cluster. So all the hospitals within the public healthcare cluster, Tan Tock Seng, Woodlands Health, the specialist institution like Institute of Mental Health, Skin Center, and of course the polyclinic itself, they are using our platform. And through the platform itself, they deliver all the telemonitoring, teleconsultation, telerehab services. But because Singapore is very big in terms of population health, so we also do holistic care where the resident can use the system to keep themselves healthy as well. And to show the power of what we have done, because we've implemented not just a hard-coded system, we've implemented a system whereby our partners, our client, our customers can continue to create new programs for their own needs, new programs where it is more suitable, customized for their own patient, their own population. If you look at the bottom left, when Singapore rolled out the Healthy SG program, which is our population health program in Singapore, it only took us 3 months to deploy the population health program on our platform, because with the platform already in place, connected to all the hospitals and so on, all we need to do was go on our platform, create new material, create new content, and deliver a brand new program aimed at the entire population in just 3 months, right? Now, of course, at the bottom, those are some of the services that are already included within this whole system. And this is already secured because we understand that clinical data cannot go onto public internet. So we have already segregated clinical data versus public versus program, consumer, patient, lifestyle information. And again, satisfied to the level whereby we have worked with the MOH in Singapore to make sure that the whole system is secure and safe to be deployed. And this is a graphical example of some of the programs that's rolled out. And again, if you look, even though they look all very different, but these are all deployed through the same platform, right? Of course, through different front end, because different user, different needs, whether it's a patient or put in the center, there are different requirements. But if you look at it, they are all controlled, managed, deployed through the same platform. On the bottom left are there's one for cardiac patient with a real-time heart rate monitor. There's one for COVID, which we created during the COVID itself. We have a chatbot, much like what MD has done. Yeah, so this is for rollout to WhatsApp. This is a health coach. Yeah, and there are different illnesses that it can be tailored and created to look after. So what we've done here is a diabetes health coach, where it evaluates even the food that you eat, the kind of calories that you have, what's remaining, you have taken medication and so on. And in the center there, there's a movement-based game that was created for Parkinson. At the top are the video consultation. Yeah, we have a fiscal once a month, once in 2 months visit to a hospital. We have a video consultation once a week, twice a week, where you see the doctors online. And of course, every day you use the app itself, or you go to the WhatsApp, the messaging channel, whereby it looks after you every day, or you go and do your self-care management every day. Yeah. So again, we understood all these phases that are required, and we provided all the front end, the content, the programs needed. And at the bottom right, you see something that we call the health kiosk, where it's put into rehab centers, it's put into daycare centers, nursing centers, yeah, whereby it's kind of self-activated, where the seniors play, and it brings them through frailty prevention, it brings them through their stroke rehab, and largely self-administered, self-run within each center itself. So really what we came here today was, the message is that we have done what we will call a digital health infrastructure, right? So of course, it's a platform, but we call it digital health infrastructure because it connects all the different stakeholders that is needed to provide the digital health care that you want to deliver to your patient. We have already done it, kind of proven it within Singapore, but we are also working with 2 cities in Philippines, 3 cities within China, with Indonesia, and with the private sector, we are also speaking to Vietnam and other countries in terms of doing it for the private healthcare as well. Yeah. So again, we can scale as large as at the government cluster level. We can scale at the city level, connecting all the public health, the health centers, the community health workers, and bring them together and basically provide them with a very cost-effective way to roll out digital health in the country, in the city, province, or within the private healthcare sector. Yeah. So I've shared my email here. Happy to have further discussion with anyone who's interested. Thank you, Lisa.
Thank you very much, Mr. Senbio. I understand you're working directly with the local government units, I think in Pasig, right? And in Batangas. So we
That's
can
right.
discuss more about that later.
Yes.
Okay. So we have another two last speakers. Dr. John Lewis and Mr. Sam Bufa, who are with the HISP, Health Information System Program, which is a global network of information system experts coordinated by the University of Oslo. Dr. John Lewis is the director for HISP Vietnam, and Mr. Sam Bufa is the coordinator for the OPDR. Both are working to strengthen digital health infrastructure, surveillance platforms, and data-driven decision-making. Welcome, Dr. Lewis, Mr. Bufa.
Yeah, thanks. I hope you can see my screen.
Can we do full screen?
Yeah. Great. Thanks all. So today, like we have, what I'm going to try to present is about HISP in general and like the HISP in Asia, and then my colleague will explain more our work in Lao PDR on dealing with how best we are using technology and DHIS2 for strengthening health system in Lao PDR. So just to tell a bit of background about HISP, HISP stands for Health Information System Program. It is a global action research network initiated in 1994 in South Africa. It was led by the University of Oslo. Currently, HISP Center in University of Oslo is leading the DHIS2 software, so it's an open source platform, which is developed by University of Oslo, but not only the University of Oslo, but many other universities in Tanzania, in Indonesia, in other countries, and in Africa, and also the people are collaborating to build this global public good. the DHIS2 and the HISP network is been basically financed by global health agencies such as NORA, the Global Fund, PEPFAR, Gavi, CDC, UNICEF, Gates, USAID, and WHO. During the COVID pandemic, like we got quite some funding to support the countries on implementing COVID certificate, build a system which was implemented in many countries, including Sri Lanka, Laos, Vanuatu, and other places. HIP Center in University of Oslo is a WHO collaborating center where they work and also present lots of WHO metadata packages which can be used inside DHIS2 for the country use cases. DHIS2 it's been used by 89 countries in the world, and in specifically in Asia and Pacific region, it's more than 30 countries are been using DHIS2. So coming to like what is DHIS2? So DHIS2 is a web-based platform which is used to collect not only aggregate data but also individual data and the event data, which is called line listing data for all the use cases. It's a fully open source and customizable and can be also be locally owned. Customizable doesn't mean that like people need to know programming. Like the one of our whole focus is on giving the power for the health administrators and the people to use the UI itself to configure the forms they're collecting, like the all the different rules, validation rules, and everything can be configured without having enough programming knowledge at all. DHIS2 also has an offline version using the mobile, which can also use the SMS. It can use the internet, and also like it can send notification for both for the healthcare worker and also for the patient to remind your next visit is so much. Please come for here. Send the alerts for during the outbreak, and it also has a built-in package of analytical tools such as dashboard, maps, charts, tables, and it can actually just see many of the activities over time. We also have something called extend the app during the COVID. We were expanding that one for including the COVID certificate using um, the QR code and the cryptographical verified QR code. But now, like we are also since the climate initiative, so we've been also integrating climate data into DHIS2, so that like the countries and the people can actually download not only the global data from the ERA5 from other sources into their own country level and analyze the climate trends with respect to the health. We are also in the process of doing the prediction, like based on diseases patterns and all things and the climate changes, like how you can try to predict whether it is dengue, malaria, or like air quality cases and all. So those things are something which we've been like working towards. So HISP, apart from the HISP Center, there are multiple HISP groups which are basically focused on supporting countries. So in the world, we have 24 HISP group in Africa and Asia and Latin America. And the University of Oslo, the HISP Center, is acting as it's a main center where it actually uses the different HISP group to coordinate, and also like we support the development and getting the feedback from the community itself. This for all the 24 HISP group have been endorsed and funded by Global Fund. This actually started in 2022, where like we wanted to support not only one country but multiple countries. So during that process with the Global Fund and Gavi, HISP groups were created, both HISP Africa and HISP Asia group, where all the TAs and everything were been uh, contracted via one group instead of all the 24 groups. And then like all the HISP group have an MOU with University of Oslo, the HISP Center, and like we share the same principle, like that collaborative and sharing the knowledge, free and open source, local ownership, making more transparent and accountability of all the work. So these were a few of the key objective of the HISP network, where we wanted to support and help not only the Ministry of Health, but other organization who wants to use DHIS2 for implementing in their country and organization. Coming to HISP Asia. HISP Asia is a consortium of 7 HISP group in Asia region. It includes HISP Bangladesh, HISP India, HISP Indonesia, HISP Middle East and North Africa, HISP Pakistan, HISP Sri Lanka, and HISP Vietnam. HISP India act as a secretariat where if there is any kind of contract comes to the HISP Asia, so HISP India takes the role, and then other HISP group will collaborate in implementing, supporting the countries or multiple countries together. So we have accomplished few of the things in 2021 with respect to the Global Fund. There were 6 countries, Afghanistan, Myanmar, Sri Lanka, Pakistan, Bhutan, and Nepal, where we did the maturity assessment, even though it was done by different HISP group, but it was all through HISP Asia Hub. And there were different 18 technical assistance on DHIS2 itself, so which was basically given to upgrade of the DHIS2 maintenance of all the things, creating the dashboard, implementing WHO's profile like HIV, TB, and malaria, and also like we were able to have 2. Currently, we had 5 HISP Asia conference. Last one was in October in Bali, led by HISP Indonesia. And with UNFPA, we also did HMI's assessment in 7 countries. We did a series of webinar, basically on data analysis and data quality, how best like the data which has been collected can be used and utilized for the local action. We also had a couple of joint projects with WHO Zero, where we help the different countries in specifying or helping the countries in building from additional modules or giving more tailored focus on DHIS2. We also built a communicable disease surveillance assessment in Myanmar, Indonesia, and Thailand. With respect to WHO Zero, we used ICD-11 mobility in Bangladesh with WHO Zero, HISP Vietnam, HISP Sri Lanka, and HISP Bangladesh. And same, like we try to collaborate in doing the DHIS2 maturity assessment in Laos. That was basically done by HISP India and HISP Vietnam. HISP Vietnam as an organization is a part of HISP Asia Hub and the University of Oslo. It is a member in the global HISP network. It's based in Ho Chi Minh City, but like we usually work with the different ministries and the health organization in implementing DHIS2, training and use of data. We also work very closely with the Ministry of Health in Vietnam, Laos, Cambodia, in Pacific Islands, Tonga, Solomon Islands, and Vanuatu. Now I will hand over to my colleague Sam, who will share his experience on Lao PDR. Sam, over to you.
Okay, thank you, John. And good afternoon, everyone. I'm happy that I have the opportunity to share our experience supporting and working closely with the Ministry of Lao PDR. Next slide, please. So I would like just to start with the achievement from the Ministry of Health side. As you already know, Ministry of Health Lao PDR is using DHIS2 as an integrated HMIS platform, and we have been working closely with MOH, with the local partners to integrate with all these health programs into DHIS2. And so far, since 2013 until now, we have more than 15 health program reporting directly into DHIS2. As another part that I'd like to mention, because DHIS2, as John mentioned, not only for data collecting, right? We want like especially health program and ministry or department to use it. Now that we have data in one location, as you can see now on the right side, there are some products that have been producing from this integrated platform. So we had the MDG dashboard at the time. Right now we also have a national assembly dashboard. That's where MOH need to report the progress on the key indicators to the parliament. Apart from that, Ministry of Health also produce annual statistic report using data from this integrated platform. Yeah, next slide. And that one is most of the work we did from 2013 until now, and most of the program are reporting using an aggregate format. Right? That's because Lao just started using DHIS2 and to switch from or to move away from paper-based and Excel to digital using DHIS2. And so far, many programs were using or reporting as aggregate, but now when people are familiar with DHIS2, health workers are comfortable with using the tool to report or to see the data. There are more need to see more granular data. And as you can see now, many programs are moving from aggregate to tracker. Tracker meaning we like to capture or focusing on individual level data. As you can see, there are many few programs started first in 2018, like malaria, HIV, TB, and now moving forward into 2023, where MCH or EAR is also would like to see data in individual level, because aggregate can take us far, but to reach the last mile, this individual record is very essential. And there are some plans in the future about NCD, about cancer, that we are working with WHO country office, try to include this into the HMIS. Yeah, next, John. Apart from the program moving to individual level data, but if we don't have this core infrastructure that Dr. Chansali mentioned in the digital health strategy, right, it will still be a silo program, meaning all the program will still be program centric. And that will be a limitation for HMIS. So apart from that, in digital health strategy mentioned that now all the program need to share data and to move away from program centric to person centric, right? Because the person will be give or receive services from different program, but at the end of the day, it's the same person, or the same person can visit different hospitals. Why we need different IDs for the same patient? So that's the plan, and is current in progress and starting with many programs. Now we have one database called Client Health Registry, where the Client Health Registry will be the database to consolidate all the patient record, issuing the ID for using in the health system. So that now, regardless of the patient receiving services at any facility or any program, will be using the same ID. That's next, John. Yeah, and I would like to highlight now we have the same ID. Every facility, every program will utilize the same ID. That is enable the sharing of data. And many hospitals right now, especially the central hospitals where they see the importance of data and digital, they can afford the EMR or the hospital management system, so that now they don't need to report to the HS2 if they have their own data can be shared. And in some part of the country, for example, especially at health centers or at district hospitals, they can still report to DHS2. But then at the end of the day, this data will be linked through CHR and through the same ID. But not just from the health sector, right? We still can share data with other ministry like MOHA and the Ministry of Home Affairs, where they also collect the birth and death. This data can be shared, and in terms of the birth, Lao also have some, or in terms of the challenge of collecting data, there are some data or birth happening outside of the country. But at the end of the day, MOHA will be able to capture that, and that through this architecture, then data can be linked and shared. Next slide, John. Okay. Yeah, next slide. But now, No, go back. Yes. But that's just how we are doing. But now, as we mentioned, because Laos is using DHSU and many facilities, especially district hospital, provincial hospital, health centers, they report into DHSU in either aggregate or now many are reporting as individual level data, and many hospitals are reporting for many programs like ER delivery, what we see as the potential use case, and that we discussed with Dr. Chansali and MOH, now that DHS2 can turn into potentially can be a mini EMR, right? That will help all the facilities, especially the small facilities, to stop using paper, and with EMR, then all the data can be captured and then it can be linked. And then that's a potential milestone to stop paper-based entirely and then moving fully to digital. And that is something that we are exploring, and we are working closely with all the partners to see if this is can be a further next step. Yeah, next, John. That's just the plan and also the future potential. I'd like to show you, like John mentioned, many countries where they use the HS2, they also did assessment. Laos just had one with the support from WHO and HIPS India. We are working alongside just to conduct the assessment of DHS2, how mature of DHS2 in Laos, since Laos have been using DHS2 for 10 plus years. And as you can see now, all the foundational are very strong and very mature, and that give us the confidence into moving forward to really use DHS2 for tracker or to capture individual level data. The next one. And just to highlight the recent achievement from moving to tracker is the EIF program, where they fully switched to digital to track individual children and stop using paper and Excel. And one highlight that I can mention during the celebration is to highlight that now, because the aggregate in the past, health worker struggle, right, to follow the child or the children in the catchment, because they have to go through all the papers and to see if any child is missing any dose. But with the use of digital, now this can be automatic, and that's what we can see now. In terms of the health worker, they can see the potential useful of the system, that they can tell them or remind them if any children are likely to miss the vaccination. Next, John. That's just for health. On health, now I would like to mention a bit on the climate. This is something that Laos is taking fully into consideration, because Laos is also affecting or got affected from climate a lot. And we have been working with Ministry of Health as long as Ministry of Environment to include local weather data into DHS2, since many we have like surveillance data into DHS2, and then we work with with WHO to see if there are any correlation. And as you can see, there are some correlation there in terms of to see the dengue. But then next slide, John. So fast forward, we work closely with many partners now to include more climate data into DHS2 to see, and we highlight 3 potential use cases. So the first one is dengue. That's the previous slide, just to show you how we compare. But now with climate data, with temperature, with rainfall, we can, and with the model from University of Oslo, we can try to see if we can predict the dengue outbreak. Another part is also on flooding. Laos also have two seasons, right, hot and rain. But during the rainy season, there's a lot of heavy rain and including the flat spot. And we are exploring, we are working with the Mekong Regional Commission to see if we can use this one to be the early warning of the flash flood, and then any intervention we can do in order to protect the health centers. And on the PM 2.5 as well. Next slide. I have 2 slides remaining. I think we run out of time, but I can highlight just the key challenges. I'm not going to go through. So the first one, as you can see, even we have Laos has the strong foundation in DHIS2, but mostly about sustainability is something we would like to work more on that. As currently we are relying heavily on the external partners. Right? And in terms of the data, we see many data coming in, but in terms of utilization, it's still limited. Next slide, John. But in terms of the next step, that's what we would like to focus as part of the HIPS Vietnam or HIPS Asia and the HIPS network. We like to build the capacity. That's the core of HIPS. Right? We would like to empower the local staff, the local government to take on. So in case that they don't need to rely on just one organization. And in terms of the data use, that's something we are focusing on how now we can utilize data. Now we are moving to individual, then we even need to visualize data and make use of it more better. And other part as well that I can share with you later. But I think we can go to the last slide, I think. Yeah, I think there are many things to talk about. We have limited time, but if you would like to learn more about our work in other regions as well, like in Vietnam or Cambodia, you can feel free to reach out to us. And with that, I would like to hand over to Lisa. Thank you.
Thank you so much, Sam. Thank you so much, John. Important information about the climate and health, and then there will be another webinar related to that. So I think, and Alexo has a project in Laos related to climate and health. Okay, I think we're running out of time. For questions, I mean the speakers can answer online, right, Sarah? We're like 5 minutes over time. So how do we go about it, Sarah? They can just answer online, right?
They can type the answers, Lisa, on the Q&A.
Okay.
Yeah.
And then I'll just send the questions I received through Viber and WhatsApp to the speakers. Okay. So I'm sorry about that. It was a very exciting sharing. So we hope to have another webinar related to digital health. May we call on Alexo, please, to close this session? Alexo.
Yes, sure. Thank you. Thank you, Lisa. And thank you, distinguished speakers and participants, for joining in today's very exciting webinar. Just a few points on digital health systems to close today's session. I think that we're all aware here that digital technologies can really improve the efficiency of health systems. Enterprise resource planning systems can improve everything from the core functions of health systems, right? Financial management, procurement, and so on. Electronic medical records can improve delivery. Telehealth can bring healthcare delivery to hard to reach populations, help with monitoring them, and so on. Now, to be effective, these solutions need to rely on sound processes, which are not always present. To give an example, in a country where we're supporting an EMR, we found out that patient data has to be collected on paper, regardless of whether it's also collected through applications. That leads to the double burden of health workers, non-value added double burden, and it really undermines the acceptability of IT, right? Which really can have consequences over the long term. So it's really important to redesign processes before implementing many of these applications. It's also very important to invest in the digital building blocks. These include developing minimum data requirements, developing standards for interoperability, for unique IDs, and so on. Also developing registries of facilities, patients, and providers. And it was mentioned today, safeguards for data privacy. It's also necessary to develop data governance framework to ensure that the data are actually credible and relevant. Now, this is not the sexiest IT type of work. It's often tedious. It requires a lot of coordination. For example, something as simple as the IT system can require strong coordination with the Ministry of Interior, right? However, it really pays off over the long term. if one wants to achieve an interoperable system. Digital applications on a more mundane level also need a supporting environment. It was mentioned today that electricity and internet connection is not available everywhere, right? It's also in some countries, literacy is not, some of the countries in our area have illiteracy rates of 20 to 25%, right? So if people cannot write their names, how can we expect them to use digital applications? Often pretty mundane breakdowns can stop the use of digital applications, such as not having paper, for example, to print patient referral forms of or medical prescriptions. So it's really important when piloting electronic medical records or whatever solutions it is, that we take all these factors into account, which are often easy to forget when we're doing our work, you know, in the capital or here in Manila. The private sector, of course, always plays a key role in IT systems, in developing applications. There are very, very often implementation partners, but they can be also partners to test the acceptability of data standards, minimum data requirements, and so on. Because in the end, you know, we need to rely on them for collecting a lot of data. But ultimately, of course, attaining an interoperable system has to rely on the government. You know, the government has to lead with policy dialogue and so on. So thank you for today's invaluable discussion. I look to further discussion. You're welcome to put your questions here on the chat box, and we would like to invite you to the next seminar, which will focus on next generation TB modeling and diagnostics. So thank you so much. Thank you, Lisa. Thank you to all the speakers for giving us an hour and a half of your time today, and very nice to meet you all. Thanks.
Thank you so much, Alexo. Okay, do we need another photo, Sarah? Or we're good?
We're good, Lisa. Thank you.
Thank you so much.
Thank you,